if you're trying to do projects and score points, teaching kids CPR is probably one of the most useful things you could do, rather than a lot of the other stuff. And that's all talked about in this bit of the guideline as well. Another point that they've mentioned is talking about if you have a cardiac arrest in the community, out-of-hospital cardiac arrest, then should he be taken to a special cardiac arrest centre? And the suggestion is that if you've had a non-traumatic out-of-hospital cardiac arrest, then probably you should. They do make the point that there isn't really any evidence to support whether you should go directly to a cardiac arrest centre, or whether it should be from a secondary in-hospital transport after you've gone to wherever. But if you've had what is suspected as primary cardiac etiology, you should go directly to somewhere that can do PCI. In Leicester, I think we just about achieved that. I know that a lot of the cardiac, does that make sense? The cardiac arrests do go directly to Glenfield, whereas in the Royal here we tend to get a lot of the, slightly more, slightly more variable causes of cardiac arrest. So, and then sometimes we transfer them, sometimes we don't. So I think we just about managed to achieve that. They've updated the ethics section slightly in the guidelines, and the real point they hammer home in this bit, it's quite a long section with a lot of discussion about how you have these conversations, but it's to use advanced care planning and to use respect forms, and that actually we shouldn't be offering CPR to people where essentially it's futile. They don't define what futility is, but I think that comes from experience from meeting these patients and managing these patients. Right, so now if we move on to the cardiac arrest algorithms, and there's a few bits and bobs to pick out, but there's not really any real change to any of the algorithms. So I've tried to go through them a bit and pick out some of the interesting bits which aren't on the flow charts, but are kind of buried in the text, if that makes sense. Again, these are all now blue, not red. There is a myriad of flow charts, most of which don't, well, in my opinion, don't really add a great deal to any kind of emergency situation. But I mean, I guess most of them are guidelines for planning situations, preemptively planning things. The point they make before we go into the algorithms is the most important thing you can do to manage a cardiac arrest is prevent it happening in the first place. So they're talking about track and trigger, early warning scores. They don't name it explicitly, but things like outreach services and similar kind of things like that. So the first little algorithm that we'll talk about that they've published is the adult in-hospital resuscitation. So this is one of the flowcharts that isn't particularly useful to follow through. But essentially all this is trying to divide people up into cardiac arrest and into medical emergency. And the pathway at the beginning is essentially the same. They talk about call and collect now, which is basically call the resuscitation team, collect the equipment you're going to need. And then you either immediately start CPR and go down the ALS algorithm, or you have a medical emergency team come, who are probably the same people who decide, what you need to do with that patient to progress them forwards. The adult advanced life support algorithm remains the same. There was quite a lot of talk apparently before these guidelines were published that adrenaline might be taken out of the algorithm, and that comes from the Paramedic 2 trial, which is a study in looking at out-of-hospital cardiac arrest, which and what that showed was that although adrenaline will keep you alive and keep your heart beating, the neurological outcomes and the long-term outcomes were much worse in those patients. So there was some suggestion that people might take adrenaline out. And I listened to a talk or a podcast or something by the author of Paramedic 2, who was suggesting that actually there's so little evidence for having adrenaline in the ALS algorithm. If you were going to write it now, it would be difficult to put it in, but it remains in. And there's another trial, I think it's called Paramedic 3, where they're looking at what doses of adrenaline we should be giving. But anyway, so the algorithm remains the same. So for those of us who aren't used to ALS, essentially we do 30 chest compressions to 2 ventilations until we've got some airway management, which we'll come talk to in a minute. assess the rhythm, and then that you fall down either a shockable or a non-shockable pathway. So the non-shockable pathway, you give adrenaline as soon as you can, and then do 2-minute cycles of CPR with rhythm checks. The shockable pathway, you give adrenaline and amiodarone after the 3rd shock. And then something which I've maybe missed in the past, that after the 5th shock, you give another 150 milligrams of amiodarone and then optional 50 milligrams of lidocaine, which is something I don't know if that's new, but it's something I've not, maybe I wasn't listening at that point, but it's something I've never done. And you go around the cycle until you either get ROSC or you stop, which we're going to talk about a bit more in a minute. So don't worry about reading all the things on this slide. These are just things that I've picked out, which are written in the text. So we should be aiming to, from recognition of cardiac arrest to defibrillating people in under 3 minutes. And the real point that this is making is that anybody who works in a hospital should be able to, if they recognize a cardiac arrest, stick an AED on and defibrillate the patient. Whether or not that's achievable in practice, I don't know. I think it would be interesting to see how long it does actually take us to defibrillate patients. I suspect it's a lot longer than 3 minutes. Interruptions for whatever we're doing, whether that be defib pad position. Now, this is something that maybe I didn't know, and I've been doing maybe, well, what it is. Anyway, yeah, so if you've got people who are prone and need defibrillating, they suggest using the biaxillary position. It's gone away now. Don't know. It's just my echo, my voice is just feedback of my own voice. Energy levels, I think they've recognized that there are lots of different defibrillators out there, and that I'd say most of us probably don't really know what energy level we're supposed to be setting it at. So they've just suggested that we set it anywhere between 120 and 360 and just increase the voltage with subsequent shocks. I mean, what I've always done is just turn the defibrillator up to the maximum setting of that defibrillator and just use that for cardiac arrest. I don't really see the point in giving a small shock and then a bigger shock. Doesn't really make a lot of sense to me. But we'll talk about, there is some discussion about energies for different kinds of shock later on. In terms of airway management, this is, I mean, I think this is something that I've certainly changed my practice over the last few years. What they suggest is that if you're going to try and intubate a person with a cardiac arrest, it should take less than 5 seconds, and the person who's doing it should have an expectation that they would have a 95% success rate within 2 attempts. Your other option is to put a supraglottic airway in, and there was a trial called Airways 2, which was again about out-of-hospital cardiac arrest, that actually showed there was no benefit in intubating patients in cardiac arrest when you can just stick an eye gel in. I now just treat intubation as a post-resuscitation. What they do make the point of stating is that Yeah, of course you can.
With the
Intubation. Yeah, I would. If somebody intubated on if somebody had a cardiac arrest on the unit, I mean, admittedly, the people on intensive care are better intubating than often on a ward, for example. But we run out of. Adrenaline kind of 5 minutes into resuscitation, then I think if you're still struggling with IV access, using the ultrasound for. We shouldn't be stopping resuscitation based on that. Okay, right, so this one's a bit more topical, well, locally anyway. ECPR, ECMO, consider extracorporeal CPR as a rescue therapy for selected patients. And this should really just to be as a bridge to get them through to either a thrombectomy or a PCI. I know this has been done in Glenfield. I don't think it's, in terms of whether or not we can do it in the Royal, I don't know if any of the ECMO people have an opinion on this. I don't know from a practical point of view how we could do this in the Royal realistically very often. I mean, yeah, maybe every now and again, but not very often. But maybe as the service develops in the future, maybe, who knows. Yeah, it's logistically challenging to be able to get them on in a reasonable amount of time while still being alive. Right, there is some discussion about when we should stop CPR. So they've got some very, what they describe as unequivocal criteria. So when you can't guarantee the safety of your resuscitator, and the reason, and I wonder if this is a nod. So I think this is largely pre-hospital, but then I wonder if in COVID times this might also be relevant as a point in the guidelines. The COVID guidelines.
Yeah, I'm on the.
But as our understanding of the transmission of COVID changes, whether or not these guidelines need to change is some. And obviously, if it turns out you've got a DNA CPR in place, we should be stopping CPR. Well, if you find somebody who's dead. Well, I think that's a bit of a. So other people are struggling to hear the presentation. Oh dear. Yeah. So we're now having a discussion about when you should put arrest calls out if you're phasing in and out of this talk. I very much edge on caution. So if you're an ALS trained provider, for example, then I think it's probably fairly reasonable to be able to say this person is dead. If you're an F1, then yeah. Well, I think it really depends whether you feel you could stand in front of. This is always worst case scenario. Can you stand in front of the coroner and say this person was clearly dead? I'm a doctor. I did not feel it was appropriate to resuscitate them. If you think that's the case, and you can defend that decision, then I think it's not unreasonable to not be resuscitating people who are dead. The difficulty comes, for example, and I think this partly may be to do with there's been a few incidences where particularly nurses in the community have found people who are dead and got into a lot of trouble for not resuscitating them. I think that probably reflects that. Yeah. But it can be a difficult call to decide, I guess, to decide somebody who is clearly dead versus somebody who has had a cardiac arrest but isn't dead, if that makes sense. Yeah. They're rapidly about to become dead, but they're not officially dead yet. Yeah, so this is exactly that. So a 10-hour wait, somebody who's clearly dead should not be resuscitated. But you have to be able to defend that decision. So the other things, the informed decision-making reasons to stop CPR. So if you've had asystole for 20 minutes, despite the fact you've had ALS and you can't find a cause, if you've had an unwitnessed cardiac arrest in a non-shockable rhythm in a patient with kind of comorbidities, that would mean that you're probably doing the patient more harm by trying to resuscitate them than by stopping. And all the other thing they suggest is that if there's strong evidence that the patient doesn't want CPR, but it doesn't really suggest what that is. things that we should not be using to stop CPR, and I think I've seen most of these things brought up at some point over the last 10 years. You know, having fixed dilated pupils is not an indication to stop resuscitation. Ongoing CPR, low end tidal or high end tidal CO2 values, comorbid state, I think that's open to interpretation. Because I think there are certainly some people who we go and see as intensive care, who we go and find out a little bit about them and just think this person should not be resuscitated. High lactate, you know, initial lactate values at the beginning of resuscitation, I think most of us have probably had that involved in a conversation. One thing that is really important is that if we are going to terminate a resuscitation or deny a resuscitation, then we need to document clearly why we've done it. And I think we're not very good at this, but it's something I think that we need to make more of an effort, especially in the, you know, the current climate. With there's been a lot of discussion about respect forms in DNA CPR over the last year. I think we need to be very careful with our documentation about why we aren't doing things. Right, so moving into post-resuscitation care, there's nothing particularly out of the ordinary in this algorithm. Essentially, it is once you've got ROSC, make sure they're well oxygenated, bring them to ITU, do normal things, cool them a bit, which we'll come back to in a minute, and then consider coronary angiography. We'll just move on. We'll move off this diagram because it's not very easy to follow. So the key points from that. So one of the things they've suggested is that this guideline is now in alignment with the European Society of Cardiology for whether or not you need immediate coronary angiography if you've not got ST elevation. The reason I put lots of question marks is that they don't actually tell you what the indications are. And if you read those guidelines, they're about 1,400 pages long, and I could not find the indications. They suggest that if you read the something else I read suggests that if you think your cardiac arrest is from coronary artery occlusion, then you should have your angiography. But how you determine that, I don't know. So I think the answer to that is still discussing with a cardiologist. Other things that have changed slightly. So, well, good ICU care. Levetiracetam and sodium valproate are now been substituted for phenytoin if the patient has seizures. We should be aiming for control temperature management, so 32 to 36 degrees for the first 24 hours, and avoid temperatures of higher than 37.7 for the first 72 hours in patients who remain unconscious. I don't think that is vastly different to what we're doing anyway. The European guidelines have much nicer pictures, but essentially this is what we should be aiming for, which are just the usual ITU targets. So good oxygenation, reasonable CO2 control, unprotected ventilation, and maintain a blood pressure that is sufficient to produce either a reasonable urine output or a decreasing lactate, and support them with vasopressors and inotropics as required. This is the kind of neurological withdrawal algorithm that they've suggested. This is from the European guidelines. There's a slightly more difficult to read version in the our own guidelines. So essentially it goes down the line of, do you think there's a neurological cause? Do they look like they've got brain death, or are they still unresponsive and losing their brainstem reflexes? If the answer is yes to all of it, or any of those questions, you need a brain CT. Otherwise, you need temperature management and neuroprognostication, which we're going to come on to, and then decide whether or not you're going to confirm brain death or go down the withdrawal of treatment. And of course, point out that they could die at any time at the bottom. Right, so how do we neuroprognosticate? This is something which is always I've always found a bit confusing. So once you've done your temperature management and you've rewarmed the patient after your 24 hours of being cooled, if you've got a motor score of less than 3 at 72 hours without any co-founders, and they are essentially sedation or severe metabolic derangements, then you need at least 2 of, there's a list of things which are on the next slide, which will suggest that you've got a poor outcome. But it's much easier to read. Ooh, dear. It's much easier to read on this slide, which is from the other guidelines. So if you've got a motor score less than 3 at 72 hours, and you've got no pupillary and corneal reflexes at 72 hours, a bilateral evoked potentials, N20 evoked potential wave, but a high malignant EEG, neurospecific inlays, and they've now given a figure to that, although I don't think we can measure it locally, where we've got status myclonus, which they define as half an hour, 72 hours, at less than 72 hours, and whether you've got extensive brain injury on CT. So if you've got two of those, then your outcome is likely to be poor. What they do make a point of, and this is their phrase, not mine, is beware of the self-fulfilling prophecy. And by that, what they mean is that if you've got one of those things which is bad, and you think it's bad, and you think the outcome is going to be bad, and then you basically make your decisions based on that, then you will have bad outcomes. So you need to be a little bit careful. They also point out that we need to consider other factors as well. So, you know, a young person with no comorbidity, even if they are fairly catastrophic early on, has a more realistic prospect of survival than, you know, an old person who has the same catastrophic kind of the same negative factors from that previous table. Okay, there's an algorithm for organ donation after cardiac arrest. I don't think this differs at all from what we do locally. Essentially, do you have signs that you may have a neurological cause of arrest, and then you need a CT, and then you can descend down into whether or not you've got death by neurological criteria. If the answer is no, are you managed properly? Are you still unresponsive? Do you have all the negative features? Then would we consider withdrawal of treatment until they go in for organ donation? And I think that's exactly what we do locally. This is just a very quick slide for what we should be doing when we discharge these patients. So we should make sure they have all their functional assessments done before they're discharged from the hospital. And then they should all be followed up at 3 months, because cardiac arrest patients often have quite considerable cognitive, emotional functional problems. And just to provide a bit of support and kind of a debrief for them and their family as well. Right, so we'll just very quickly talk about some of the other little algorithms. I keep calling them little algorithms. They're not little algorithms. They're the Resuscitation Council guidelines. The adult tachycardia algorithm is pretty much exactly the same. The only thing that they've slightly changed in the text is that for atrial fibrillation, we should just be giving an initial synchronized shock at a maximum energy, rather than, again, what I think people often do, which is give a lower energy shock and increase it. And then if you've got down to the so that's for the unstable bit at the top. And then if you come down through the bottom bit and you end up in the unstable bit, then we should be giving lower energy shocks for kind of synchronized cardioversion. And then if you're not succeeding with a low energy, then increase your energies. The little question marks which I've drawn on, just to remind me that one of the points they make is that if you've got atrial fibrillation, then it doesn't quite match what's in the text with what's written in this box. So they say control rate with a beta blocker, considered amiodarone or digoxin. So in the text, what they suggest is that you should give amiodarone unless they've got severe LV ejection fraction of LV impairments with ejection fraction less than 40%. In which case you should be giving them a small dose of beta blocker to try and get that heart rate below 110, plus or minus some digoxin. It's just slightly different from what's written in that box. But I don't, I think it's probably just a different way of managing the same situation. Adult bradycardia has stayed the same. Essentially, it is give some atropine. If that doesn't work, give them some other drugs which are essentially atropine, as adrenaline or adrenaline. One of the points they make in the text is that if you've got bradycardia because you've had an inferior MI or a cardiac transplant or a spinal cord injury, then we should be giving them aminophylline. If you've had a cardiac transplant, don't give people atropine, because you can give them AV block or sinus arrest, so we should be giving them aminophylline. And if there's an overdose, primarily beta blockers or calcium channel blockers, then give glucagon to try and reverse the bradycardia. Right, that's essentially it, really. So in summary of the guidelines for 2021, there are very few changes. The only thing that really The only thing that's really different is the anaphylaxis guideline. There's a few little bits and bobs that are new, but none of them really affect the resuscitation algorithms. I think that just mostly we are in line with what the guidelines suggest already. And I think there probably is a bit of scope to review what happens at some of the arrests and some of the things that we're, some of the things that we actually do, like whether we intubate people, whether we don't intubate people, how quickly we can defibrillate people, all those kind of things. And, I think there's probably a few little projects in there for people who want them. Okay, thank you. That is it.
Was there a reason that hydrocortisone and it was taken out of the anaphylaxis guidelines? Did they give any reasoning for it?
Oh yeah, I forgot to ask if anybody had any questions, didn't I? No, they don't comment on it at all. It's just missing. And I have to admit, I didn't have time to go back through and work out why they'd taken it out. So I'm sorry, I don't know the answer to that question.
Fair. Thank you.
Yeah. Yeah, well, I mean, that's probably right. I mean, it probably doesn't make any difference in the short term. I mean, it doesn't say you can't give it subsequently. There's no, it just doesn't mention it. It's just disappeared from the algorithm. Well, oh yeah, no, I mean, yeah. Well, I think with intubating on the ward, if you've got no control of your airway at all, then fair enough, and you have to intubate. Fair enough. One of the comments they make is that if you can't adequately ventilate somebody with continuous chest compressions with an eye gel in, then arguably you could just go back to the 30-2. But that's a judgment call. We're all professional airway managers, aren't we? So you have to do whatever you think is best. But intubate. I mean, when I started out, people used to get intubated as a routine. That was just what people did, and you just you went out, you intubated people, and then that's what you did. And as a CT1, I'm sure that often went very well for me. So I think iGels make it much easier. I think you can have reasonable ventilation from a long time before I've finished wandering to where, or whichever one has wandered across the hospital to where the cardiac arrest is. Yeah, no, I think it'd be interesting to see how many people get intubated at cardiac arrest and when they get intubated and at what point of that process does it happen. Yeah. Any other questions? So the question to anybody who can't hear on the Teams is, if you intubate somebody at cardiac arrest, does that commit them to going to ITU if they get ROSC? The answer is no, it does not. If you intubate somebody who is, so just for example, you go to the healthcare of the elderly wards and somebody's having a cardiac arrest, and I'm not going to suggest you do it because you wouldn't, but then just say you turn up and somebody's intubated, like a very, very, very old, very frail person in a cardiac arrest who shouldn't have been resuscitated in the first place. You don't have to take them to ITU, you can just take the tube out. And whether you want to replace it with some kind of supraglottic airway, or whether you just want to take it out and put an oxygen mask on, which often I think is probably the most appropriate thing, is there's a variety of options available. But bringing somebody to ITU just because somebody's put a tube in is not appropriate. And I suppose the place that happens perhaps more often than it should is maybe ED, not necessarily in this hospital, but certainly in some of the DGHs perhaps. Maybe it does happen in this hospital more than we think. But you're not committed to taking somebody to ITU now. Oh, there you go. So the anaphylaxis question, somebody just looked it up and found it immediately, is that it's felt to delay the treatment, which is the IM adrenaline, because people are giving that instead of the adrenaline.
Excellent. So hello everyone, my name is Neil. I'm one of the F2s on ITU in Glenfield, and I'm presenting a very exciting presentation today, which is all about targeted temperature management in patients post-cardiac arrest. And if you haven't noticed, then pay attention to the background, because I spent ages looking for a background that's suited, and I thought this one was quite good. It's got red representing hot, blue representing cold. So there you go. But we'll be talking about the TTM trial mostly in this presentation, which is by Nielsen et al. No relation. So the background, the reason that this question is being asked is because patients admitted to ICU after out-of-hospital cardiac arrests have a high risk of death, and in those who survive, then, as we know, neurological deficits are quite common. And the reason that this question comes up about temperature and targeted temperature management is, is this a modifiable risk factor that we can address and potentially improve outcomes? So it's known that survivors of primary hypothermic cardiac arrest have better outcomes, and it's been seen that for each drop in degrees Celsius, that the cerebral metabolic rate of oxygen consumption falls by about 7 to 9%, and that reduces oxygen debt and in turn reduces the degree of ischemic injury. These patients who have hypothermic cardiac arrest are also protected from hyperemic reperfusion injury after effective CPR and return of ROSC due to the loss of that cerebral autoregulation and increased cerebral blood flow that occurs after the ischemic insult. And in addition to that, there might be intracranial hypertension that results, which can be catastrophic. So the advantages of hypothermia are exploited electively in various cardiac surgeries. For example, in aortic surgery, temperatures reduced to 20 degrees in order to make use of these benefits. So that's one example of it being used outside of cardiac arrest. Some of the key studies that led up to the TTM trial, which we'll talk about, one of them was the HACA trial in 2002. Not the New Zealand HACA, different one. But what this was looking at was adults who suffered cardiac arrest due to VF. And their question was, does mild hypothermia compared with standard normothermia improve neurological outcomes at 6 months? So it was a multi-centered trial. It's a multi-centered trial, randomized controlled trial, which took place in 9 centers in 5 different European countries. So there was the intervention group and the control group. The intervention group, they induced hypothermia targeting 32 to 34 degrees using surface cooling for 24 hours, and then they allowed passive rewarming. They managed sedation and shivering via protocol with midazolam and the others there. And of those 137, there's 12% failed to reach their target temperature. So the intervention group, they had induced hypothermia from 32 to 34 degrees for 24 hours. The control group, they just had standard hospital bed with no temperature management at all. Sedation protocol was the same, but by looking back through the results of these patients, it was seen that their median temperature was about 37.5 degrees or higher, which is crucial from 12 hours onwards. The outcome to this HACA trial was that more patients in the hypothermia group, the intervention group, were left with good neurological outcomes at 6 months. And if you look at the results there, it was 55% versus 39%. So 55% being the hypothermic group had a favourable neurological outcome compared to 39. The number needed to treat, they worked it out to be 6. And just as a secondary outcome, there was also a difference in mortality, favouring the group which had the intervention of hypothermia. So the strengths of this HACA trial was that it was a randomized trial with a blinded assessment, and it was one of the first clinical trials to test the theory drawn on from cohort and animal studies. So that's one of the big strengths. The weaknesses, as you can see, there's a few more weaknesses than the strengths. There's a narrow inclusion criteria. There was some differences in terms of the different groups. The attending physician wasn't blinded. That is a bit difficult whenever you're having surface cooling, but they weren't blinded. But the main one is this bottom one, is that the control group often became hyperthermic. They became pyrexial, which may be harmful. And so the difference observed between the hypothermic group and the control group with conventional therapy just could be due to that some of the patients in the control group were becoming pyrexic and actually becoming hyperthermic. rather than them being normothermic. So let's have a look at the other one. The second study was the Bernard trial, not sure. The clinical question though was what they wanted to do is to compare the effects of moderate hypothermia and normothermia in patients who remained unconscious after resuscitation from out-of-hospital cardiac arrests. Again, it was a multi-center trial. It was a bit smaller, in 4 centers. It was a randomized controlled trial, and there's 77 participants. So they looked at cardiac arrests where there was BF and then ROSC with persistent coma. They excluded women who were under 50 due to potential pregnancy, and they excluded those in cardiogenic shock. The patients in this trial were randomized by paramedics in the field to either hypothermia or normothermia. Their hypothermia arm, they were cooled via cold packs to a target of 33 degrees for 12 hours, and then they were rewarmed then after that. And the way that they did it actually was that the paramedics, they would randomize on odd days. So on certain days of the week, they would randomize to normothermia, and other days of the week, they would randomize to hypothermia. The outcomes of this one, well, patients were assessed by rehab specialists upon discharge, and they mainly looked at where they were discharged to, if they were discharged home or went to a rehab facility, or if they needed longer-term nursing beds. And what they saw then was that, again, those who were normothermic, those who were treated with hypothermia had better outcomes, 49% versus 29%. And you can see here again, in terms of the median temperatures in the hypothermic arm, they were reaching 33.5 degrees. But for those who were normothermic, their median temperatures were above 37. So again, the main strengths of this one, it was a randomized trial, multi-center, but the weaknesses is again that the control group often became hyperthermic, which could be considered harmful. So in comes the TTM trial in 2013, and what they wanted to do was look at targeted temperature management between 33 degrees and 36 degrees. So that normothermia wasn't happening, and basically they were preventing pyrexia and hyperthermia through the 2 arms of this trial. So as you can see in the box at the bottom, TTM asked whether therapeutic hypothermia was better than the avoidance of fever. And those previous trials, which we showed you, should benefit with hypothermia, but the usual care group were often pyrexial. So the clinical question: in adults that suffer an out-of-hospital cardiac arrest of presumed cardiac cause, does induced therapeutic hypothermia targeting 33 degrees compared to 36 degrees reduce mortality or reduce the neurological deficit? So 33 and 36 are the big numbers. Again, this is a multi-center trial done in 2013. It was randomized, controlled, and it was single-blinded. Took place in 36 intensive care units across Europe and Australia between November 2010 and January 2013. The inclusion criteria was adult patients who were unconscious with a GCS less than 8 on admission to hospital after an out-of-hospital cardiac arrest of presumed cardiac cause. The exclusion criteria, they didn't exclude females under 50 like the other trial, but the exclusion criteria was that if it was greater than 6 hours from ROSC. So really it's been quite selective here. It wanted people having their temperature controlled quite early. So the exclusion was if it was more than 6 hours from ROSC, if it was an unwitnessed arrest, if they were found to be in hypothermia, so if they had a hypothermia cardiac arrest, or if they had suspected or known intracranial hemorrhage. And there were 950 patients enrolled in total. So the intervention. So once they were randomized within 6 hours of ROSC, they had 28 hours of temperature management with a target of 36 degrees using invasive or surface cooling. After that 28 hours, then what happened was that they had a gradual warming to 37 degrees at 0.5 degrees per hour, and avoiding pyrexia for 72 hours from randomization. So 4 patients didn't receive it as planned. The control group then, so the intervention group there is really just avoiding pyrexia, so 36 degrees cooling and seeing what that does. The control group, again following a similar protocol, they had 28 hours of temperature management with a target of 33 degrees using the same protocols, and then rewarmed after that at a gradual 0.5 degrees per hour and avoiding pyrexia for 72 hours from then. So the outcome of this was that there is actually no difference in mortality through to the end of the trial. The follow-up period was about 8.5 months, I think is 256 days, 8 or 9 months. 48% had died in the control group and 50% had died in the intervention group. And a secondary outcome there was that there were no differences between the groups regarding their neurological status, which is interesting. The authors concluded that this trial didn't provide evidence that targeting a temperature of 33 degrees confers any benefit for unconscious patients, compared with targeting a body temperature of 36 degrees. So they found that there was, no benefit. So what are the strengths of this study? Well, it's a highly relevant clinical question. It was well designed, it was pragmatic, and again, it was blinded. The outcomes were assessed by blinded doctors. So yeah, what are the weaknesses then? So the weaknesses is that it wasn't generalizable to arrests with longer or unknown downtime, because unwitnessed arrests were excluded, like we said before. The median time to basic life support was 1 minute, which is quite good. So there's some more of the weaknesses there. The follow-up was relatively short term at the 256 days. So it was unclear whether there's any longer term benefit to these patients. And again, there's wide confidence intervals on the statistical analysis. So what's the bottom line then? The bottom line is that the trial hasn't shown any benefit of therapeutic hypothermia at 33 degrees over 36 degrees after an out-of-hospital cardiac arrest. Although not everyone quite agrees that this is the same as saying 36 degrees is equivalent to 33 degrees, but this trial didn't show any benefit. Another sort of takeaway is that if cooling a patient to the 33 degrees induces unwanted effects, then probably aiming for 36 degrees won't make that much of a difference to patient outcomes. Sort of my takeaways from this trial. But where are we now? So NICE guidance, which was published in 2011, which is actually before this came out, talks about targeted temperature management to 32 to 34 degrees. And they did publish some guidance on the use of Arctic suns and stuff in 2017, taking into consideration some of these trials. But their NICE interventional procedures guidance states that the evidence and the safety and efficacy of TTM is adequate to support the use of surface cooling, provided that normal arrangements are in place with clinical governance, audit, consent, all that stuff. They say that they note that after cardiac arrest, spontaneous circulation for patients who have ROSC can be cooled to a core temperature between 32 and 34, with the aim of reducing brain injury and improving neurological outcome. And they say that this is in accordance with the European Resus Council and the European Society of Intensive Care Medicine guidelines. Although the European guidelines state that milder therapeutic temperatures up to 36 degrees may be beneficial for some patients. So that's where we are in NICE. NICE sort of recognise potential benefits of cooling. The International Liaison Committee on Resuscitation also look at the data from both those early trials, the HACA trial and the Bernard trial, as well as this TTM trial. And they also recommend TTM as opposed to no targeted temperature management for adults. Again, they say, you can see on the last point there, they recommend selecting and maintaining a constant TTM between 32 and 36 degrees. That's a bit broader than what NICE had said, 32 to 34 degrees. And yes, that's where we are now. But what next? Very exciting. So what next is TTM2 is actually being run at the moment, and the main reason that TTM2 is being done is because there's an argument that the hypothermic group were not cooled quickly enough. There's some arguments that, you know, the patients didn't reach that target temperature early enough and then didn't get the maximum benefit from cooling. So the aims of the TTM2 trial is that it's a planned trial, international, multi-center, non-commercial, blah, 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 all the good things. But what they're going to do is the intervention period will commence at the time of randomization. So they're going to have rapid cooling by means of cold fluids, state-of-the-art cooling devices, a closed loop system, all of this stuff to try to cool the patients who are randomized quicker. It's going to be blinded again, and yeah, excitingly, you know, I know you're all, this is a burning question everybody's asking right now, when will we know what TTM2 find? So the results are being presented live on the 16th of June as part of the critical care reviews. So we anxiously await the outcomes of that. So that's where we are at the moment. That's me finished this presentation. But I've got, you know, some questions for the audience and the more experienced amongst us is, you know, in terms of, you know, working in practice, you know, how long do you do TTM for? And if they're having fevers, you know, later on in their stay with us, you know, would you actively cool them to normothermia? Do you just treat with paracetamol, let their pyrexia die down naturally? Just some questions for those in the audience, because I don't know. That's me.
Thanks. I'm sorry, I missed half of your presentation because I've been down to resus and things, but it's been a while since I've worked at Glenfield, so I can't remember what they do. But here at the Royal, we often, we don't tend to cool, we just tend to do, just to prevent hyperthermia, and aim for 36 and use the Arctic sun to do that if we need to. And yeah, we haven't really got an answer as to how long we do that for, whether anybody that's listening has any input into that.
So yeah, I think, I'm not sure about the TTM2 is not funded by industry and all that stuff, but anyway, it doesn't matter. I think there is a reason for a normal temperature, and many times in intensive care we fail to demonstrate that abnormal physiology is helpful, but I quite agree with Zoe. We're quite similar here. So we do try and control the temperature within normal range, really. We definitely don't allow people to get pyrexial. On very few occasions, sometimes I personally decide to go a bit hypothermic in a young group of patients who got a straightforward VF arrest. And again, the time you cool them, it depends, again, on the situation. It's usually about 24, 48, roughly between 48 to 72 hours, and then you start to reverse the process and make sure they don't get pyrexial after you start to wake them up, if they're going to wake up, really. But I think it's the typical research which comes with steroids as well. When you don't find an evidence for difference, then you start to look at, is it the dose, is it the timing, is it all that different things, which I think if there was a very strong evidence for mild hypothermia, we would see it quite clearly, to be honest, personally, I believe.
Yeah. Martin?
Well, and just to chip in, I think you probably missed it. So the new post-resuscitation care guideline is 34 to 36 for the first 24 hours, and then avoid a temperature above 37.7 for the next 72 hours. And after that, it doesn't specify. But you know, as Sam just said, there are plenty of reasons to be appropriately hypothermic on ITU. So you can't cool these people forever. So probably 72 hours is probably the maximum, isn't it? Really? Unless unless their temperature is completely bonkers, in which case you might want to cool them down a bit.
It starts becoming impractical after a while, doesn't it? When you want to be waking them up and they're wrapped up in cold.
I think the implication from the guideline is that the new guideline is we should be cooling for 24 hours and trying to wake them up.
I think that's what I would say we see in practice these days at Glenfield. Very few occasions we keep them more than 48 hours.
Yeah.
Majority within day 1 and 2, you start to wake them up.
Yeah. Fine. Yeah, the population that we get is probably slightly different. We don't tend to have a straightforward VF arrest in the same way that you guys do. But yeah, I think they need waking up sooner rather than later, really. Anybody else got any other comments?
One more comment, Zoe. I would say very occasionally we use the cooling devices these days, to be honest. It's very easy to maintain normothermia with simple measures. So I can't remember the last time we used Arctic Sun. We use them, but very, very occasionally these days.
Okay. Fair enough.
That might be one of the points for industry to keep investigating this.
Yeah. Then they do make nursing much more tricky.
Hi everyone, my name is Anam. I'm one of the IMT2 doctors, and today I'm going to present a study which is related to tranexamic acid use at subarachnoid hemorrhage. It was a randomized controlled trial, and it is very recently published in the Lancet in January 2021. Okay, so basically, I will start with telling a little bit about the history of tranexamic acid use and how we came up to this ultra study. In 1984, the beneficial effect of long-term, that is throughout the hospital admission of tranexamic acid in subarachnoid hemorrhages was known to reduce the rebleeding risk. However, it increased the risk of delayed cerebral ischemia and therefore failed to show any beneficial effect on clinical outcome. And then in 2000, long-term tranexamic acid combined with standard nimodipine treatment and maintenance of normobulimia was shown to reduce the risk of rebleeding without a concomitant increase in risk in delayed cerebral ischemia. However, when the delayed cerebral ischemia used to occur, it was often the cause of very, very poor clinical outcome in the antifibrinolytic treatment group. Therefore, in 2002, a randomized clinical multi-center trial showed that a short-term, which is like less than 72 hours treatment with antifibrinolytic therapy, reduced the occurrence of rebleeding with no statistically significant increase in delayed cerebral ischemia. And it also showed a tendency towards improved clinical outcome. But unfortunately, this trial that was done in 2002 was not powered to show any effect on clinical outcome. It was mainly powered on the fact that it should reduce the rebleeding risk. So in Ultra study, they were looking at the clinical question basically was that in adults presenting with subarachnoid hemorrhage, does ultra early short-term treatment with tranexamic acid improve the clinical outcome at 6 months? And important to mention here is that they are talking particularly about aneurysmal subarachnoid hemorrhage and not the other causes of subarachnoid hemorrhage in the study. So about the study design, it was a multi-center prospective randomized trial. It was non-blinded, other than the assessors that were actually assessing the patients after 6 months. These were specialized nurses who would then call the patients after 6 months and then assess how they are doing, looking at the modified Rankin score. It was done in 24 sites in Netherlands, 16 referring hospitals, and 8 subarachnoid hemorrhage treatment centers were included. Data was collected from July 2013 to July 2019. And the procedures that were followed was once patients were randomly assigned to the tranexamic acid group, they were started immediately after diagnosis in the presenting hospital with 1 gram bolus followed by continuous infusion of 1 gram every 8 hourly terminated immediately before aneurysm treatment or 24 hours after start of the medication, whichever came first. Also, the tranexamic acid treatment was stopped if no aneurysm was seen after the diagnostic workup, that is the CT angiogram, when other intracranial pathology was responsible for the subarachnoid hemorrhage, or when the patients or their legal authorized representatives would refuse the treatment. So the primary endpoint was a clinical outcome at 6 months, which was assessed by a modified Rankin score, and it was dichotomized into a good outcome, which is 0 to 3 modified Rankin score, or a poor outcome, which is 4 to 6 clinical outcome. And both primary and safety analysis were according to intention to treat. So population that was included was anybody age 18 years and above who were admitted to one of the participating centers, symptoms onset less than 24 hours, and then obviously a non-contrast CT confirming a subarachnoid hemorrhage. An exclusion was any other cause of subarachnoid hemorrhage other than aneurysm, for example, traumatic subarachnoid hemorrhage pattern on CT, then ongoing treatment for DVT or PE, any hypercoagulability disorders, pregnancy, creatinine of more than 150, and then imminent death within 24 hours. Those all were excluded. So about the allocation profile, so there were total 955 patients that were randomly assigned. 480 were allocated into the antifibrinolytic group, and 475 were allocated into the control group. Out of those, 460 actually received the treatment, and 473 were in the control group. And then total, after exclusion, some of them lost follow-up, some of them did not give consent. There were a total of 475 patients that were actually given tranexamic acid, and then 470 who were in the control group. So baseline characteristics of all these patients were quite similar. I hope this is visible to everybody that, so female ratio was almost same in both the groups. Even the male patients were almost same, 31% and 34%. They were using some grading scales, which are basically used for subarachnoid hemorrhage group. I've used them in my next slide. One of them is World Federation Neurosurgical scoring, and then there was a Fisher grade scoring. These both scores are used for subarachnoid hemorrhage. And then medication-wise as well, these patients had quite similar baseline characteristics. I've just put a slide just to show World Federation of Neurological Surgeons. This is a scoring system used for subarachnoid hemorrhage, and basically it is a grading system for clinical severity of subarachnoid hemorrhage. And the other one is the Fisher grading scale, which is a radiological grading system, just to see how much severe the subarachnoid hemorrhage is and how much risk is to develop a vasospasm. So primary outcome, as I said, was a good clinical outcome at 6 months. And this is a slide of a modified Rankin score. So you can see that post-stroke, this scale is used to see disability post-stroke. And anything between 0 to 3 would say currently moderate disability is score 3. And then going higher, 4, 5, 6 means moderate severe disability or severe disability. So basically, we were looking at good clinical outcome at 6 months and the MRS score between 0 to 3. Secondary outcomes were excellent outcome, which is 0 to 2 at 6 months, all-cause mortality at 6 months, serious adverse effects, all rebleedings before aneurysm treatment were also considered, delayed cerebral ischemia, and thromboembolic complications during endovascular treatment were also considered. So the results. Basically, if you look at the table 1, you will see that in primary outcome for tranexamic acid group, there was a good clinical outcome in 60% of the patients, and then in control group there was 64%. Quite surprising. And then in secondary outcomes, you can see that there was not much of a difference between the two groups, the control group and the tranexamic acid group. So the other way of looking at it is that if you look at the adverse events, you will see that very important aspect is that rebleedings before aneurysm treatment in tranexamic acid group was 10% as compared to a control group, which was only 14%. And it is not showing a lot of difference between the both groups. And then CT proven rebleedings were 9% in the tranexamic acid group and 12% in the control group. And then if you talk about the delayed cerebral ischemia, 23% of the patients in tranexamic acid group still developed delayed cerebral ischemia and 22% in control group. So there was again not much of a difference in both the groups. Another important point is that the median time to start aneurysmal treatment, the surgical intervention after CT diagnosis was 14 hours. And the median interval between the first signs and symptoms suggestive of aneurysmal subarachnoid hemorrhage and the actual start of tranexamic acid infusion was 3 hours. And it is said about the rebleeding phenomenon post-subarachnoid hemorrhage that it usually occurs in the first 24 hours. And even in these first 24 hours, majority of the rebleeds are actually occurring within first 3 hours. So if you look at this, the median interval time between the first signs and then the symptoms suggestive of aneurysmal subarachnoid hemorrhage and then actual start of the treatment was actually around 3 hours. So this could have been making a difference. Conclusion that was drawn in the study was in patients with a spontaneous CT proven subarachnoid hemorrhage, presumably caused by a ruptured aneurysm, ultra early tranexamic acid treatment initiated immediately after diagnosis in the primary hospital with a maximum treatment duration of only 24 hours did not improve the clinical outcome at 6 months. So looking at this trial, the strengths of this trial was that this trial was powered not on the rate of rebleeding, but on the clinical outcome at 6 months, because long-term clinical outcome is what matters most to the patients. For optimal reduction of the rate of rebleeding, ultra-early tranexamic acid treatment was initiated as soon as the diagnosis was made. But obviously that diagnosis CT scan, which could have delayed the treatment. Only 1% patients actually lost the follow-up. Weaknesses, firstly, it was an unblinded trial, so thus it was prone to bias. Large number of patients, around 14% recruited, had no aneurysm seen on angiography, which will affect overall outcome of the study. And as I said, the angiography, CT angiogram was obviously done after some time, not immediately. So these patients were actually included in tranexamic acid treatment, but they actually did not have aneurysms. The median interval between the first signs and symptoms suggested of aneurysmal subarachnoid hemorrhage and then the actual start of the tranexamic acid infusion was 3 hours. And as I've already explained, majority of the rebleeding post-subarachnoid hemorrhage will be within first 3 hours. So this wasn't helping with the results either. In terms of recommendations, I would say because of a large proportion of rebleeding occurs before the diagnosis, and many patients in the intervention arm still had rebleedings despite ultra-early start of tranexamic acid therapy. Other strategies to improve the clinical outcome after aneurysmal subarachnoid hemorrhage should be explored, probably focusing on reducing other complications during the disease course, probably trying to control the blood pressure. And then obviously, time of surgical intervention is also important. And there are different guidelines in different countries. So that's what I would suggest. That's all from my side. Any comments? Thank you.
I think the whole concept of the trial, in my opinion, is wrong because it's been a while since I managed any neuroanesthesia, but people with subarachnoid, they're going to die from increased intracranial complications and brain injury. I mean, the whole concept of tranexamic is to give it prophylactically in cases where you expect a massive hemorrhage to prevent coagulopathy. And I don't see that's a problem in neuroanesthesia personally. I don't know, I might be wrong.
No, what they're trying to prevent is the early rebleed by giving tranexamic acid, which they're saying is the most likely cause of immediate death. Whether or not that is true or not is a different question, isn't it?
No, but I think tranexamic has been proven to be very safe in terms of coagulation, like hypercoagulopathy complications in many trials. So I don't think that's very true.
Oh, you know, I'm not disagreeing with you at all. The other thing I thought was interesting was that they said their time to intervention was 14 hours, which, I mean, from having recently worked in a neurosurgical centre, that is amazing. I don't know what kind of centre has done this trial. I mean, it's lots of multi-centre trial, isn't it? There must be better than us in Holland.
So I we believe may sort of mortality secondary to aneurysm subretinal hemorrhage, and there is rationale and there has been evidence in the earlier studies that it does reduce the risk of that. The delayed ischemia thing's another thing, but the actual the stroke guidelines for the American Stroke Association
You've completely descended into
say that they really sit on the fence. They said if there's going to be a delay to neurosurgical intervention, then there may be a benefit. But yeah, you're right. Going to theatre within 12-14 hours is amazing, which is the thing that's ultimately going to be the thing that saves your life.
Thank you to everybody that's presented. You will be on YouTube shortly. Next week is Ros Saunders, who's one of the microbiologists who's based over at the Glenfield, who is talking about some kind of opportunistic infections, mechanisms of resistance, and microbiology topics. So that should be really interesting.